Hi, my name is Janine Peterson, and my research proposal is on the efficacy of behavioral therapy on PTSD from sexual trauma. So, why choose to propose a study on the effects of behavioral therapy on PTSD from sexual trauma? Well, in the United States, approximately 81% of US women and 43% of US men have been subject to sexual harassment or sexual violence in their lifetime. And in 2018, only a quarter of sexual assaults were reported. So, this means that a large percentage of the overall United States population has likely not only experienced the destabilizing shock that occurs following a sexual assault, but they also did not receive adequate treatment for it. So, with this study, I hope to answer the question that with sexual assault survivors, would cognitive behavioral therapy be more effective than dialectical behavior therapy in reducing symptoms of post traumatic stress? And I hypothesize that DBT will be more effective than CBT at reducing symptoms of post traumatic stress in survivors of sexual violence. This is in part due to the CBT focus on restructuring cognitive distortions in reducing psychological distress, versus DBT's focus on mindfulness and distress tolerance. And additionally, much of the literature that I reviewed supports this hypothesis as well. Now, with this study, I'm not working within one theoretical framework, but four. And so they are cognition theory, which indicates that an individual's behavior and feelings are shaped by their perceptions of situations. Biosocial theory, which indicates that an individual's behavior is influenced by both their biological makeup and environmental factors. Behavior theory, which indicates that an individual's behavior is shaped by how they interact with their environment. And lastly, trauma-informed theory, which recognizes the importance of addressing an individual's trauma with understanding and in creating a safe environment. Now, cognition theory and behavior theory come together to form CBT. Biosocial theory and behavior theory come together to form DBT. And with the focus not on PTSD in general, and the fact that we are looking at PTSD that specifically comes from sexual assault, we really want to take that trauma informed approach. So we really want to work with that within that trauma informed framework. When it comes to this study, it will be a cross-sectional quantitative group experimental design. And the data will be collected pre-intervention and 12 weeks post-intervention via the clinician-administered PTSD scale for the DSM-5, or the CAPS-5. And so the data will be analyzed for improvements in overall symptoms and scores, and the intervention will be determined to be effective if it reduced symptoms and or scores in over 50% of participants in each group. So if the DBT group, if over 50% of participants showed a reduction in symptoms or or a reduction in their score on the CAPS-5, then it would indicate that my hypothesis is true. It would validate that hypothesis. So who would be in this study? The target population would be individuals who have survived sexual violence, and it would be comprised of adults, and that age starts at 18 years or older. This is due to the nature of informed consent and privacy. If we were to include minors, then informed consent would have to involve adults, and they're adults. And with the nature of this population in general, I didn't want to discourage people who would already feel discouraged to apply to be part of the study. Individuals would need to be located in New York State. This is due to licensing restrictions of the therapist who would be performing the interventions. I would prefer to have participants who have experienced the the sexually violent event within the last 12 months. And I did stipulate that the event did not have to be reported to any authorities. So if they fall within that 75% of unreported assaults, then I didn't want to keep them from qualifying. And when it comes to the study and the nature of the individuals who would be studied, there are going to be a couple of limitations. One limitation includes there just not being enough of a sample size for a statistically significant result. I would love to study at least 100 participants. However, just due to the shame and the fear that accompanies surviving such an event, I need to be prepared for the fact that I might not even get 100 people interested in the study to even be pre-screened to see if they fit within the parameters. And then there may be inconsistency in intervention delivery. Now, there will be only one therapist per intervention to kind of limit this limitation. However, each participant is an individual. They are their own person, and you can't be sure that in those individual sessions, the delivery of the intervention is going to be the same exact.